Dr. Chris Shaver here at the GI Show. Hope you are doing well, and we're glad to have you for what I think is going to be a really, hopefully, educational, informative episode on GERD, G-E-R-D, gastroesophageal reflux disease. So we're going to be talking about that today. Remember, the GI Show brings GI to the masses. It's designed to inform and educate you about common and sometimes not so common diseases of the gastrointestinal tract. So I've got a special guest for us today, Dr. Parikh. He's going to be with us. I've known Raj for a long time. He is a board certified gastroenterologist and a good friend. We've practiced together for a long time. Now we are here, I'll bring him on in just a second and we'll talk and we'll get to know Dr. Parikh. We are here today at the lovely BGA Studios and brought to you by Birmingham Gastroenterology. Check them out, including more information on reflux disease at bgapc.com. If you're watching this on YouTube, subscribe to the GI Show and like us. We'd love to answer any questions you have too. You can follow us on Twitter at the GI Show at ShaverCP. So Dr. Parikh, please join me, good sir.
Thanks for having me, Chris.
Good to see you, and welcome to your premiere time on the GI Show. We're glad to have you, and welcome.
Appreciate it. Glad to be here, and hope we can spread some good information to all our patients.
Esophageal cancer, there are several different types. The most common one that we see in this country is adenocarcinoma. And so we know, and let's talk about the precursor lesion to esophageal adenocarcinoma, Barrett's esophagus.
Yep.
So let's talk about Barrett's esophagus and its role in esophageal cancer.
So Barrett's esophagus, it's a term we use when the cells of the esophagus start to change. And this is a kind of a protective mechanism of the esophagus in your body. Your body is real smart, and it doesn't like this irritation. So it actually changes some of the lining of the esophagus to mimic the stomach somewhat, to try to protect itself from this high acid environment. And when that happens, anytime when cells start to change from one type to another, you can have some mutations and abnormal cells start to grow, which is the beginning of most types of cancers or adenocarcinomas.
That's exactly right. So, how do we screen for that?
So there's,
I know we're not great at it, and I know that there's some ambiguity in the literature. Maybe not sort of hard and fast rules. Generally speaking, like
sure.
what's a smart strategy?
Yeah.
Like somebody like, well, I'm gonna let you answer that. So kind of what's sort of a common sense strategy, or what's sort of our sort of conventionally how we're gonna screen for Barrett's esophagus?
Yeah, there are some patients, over hundreds of years of looking at this disease that are probably higher risk than others. Reflux is so common, and we can't screen everyone. It just is not efficient and appropriate in everyone. So while we're interviewing a patient and getting to know them over years, potentially, we're looking for high-risk patients. More males tend to get this, middle age, 40s and 50s. You're looking for chronic reflux, not something that's been around for a year or two and you're 30 years old. But really, it's been around 5-10 years, even if it's well controlled with meds. Smokers have a higher incidence of it. Family history is important. And these are the things that we look for to discuss with the patient. Like, hey, you're higher risk for this, and getting esophageal cancer, it's a very difficult cancer to treat. All cancer is bad, but it's a really morbid cancer and difficult treatment. And our best chance to do good for our patients and you is to catch it early in the Barrett stage, if we can.
Well said. Well said.